All right, welcome everybody. Thanks for joining us today. Today's topic is going to be plantar fasciitis, or we term it in this industry plantar fasciopathy because there may not be a lot of itis in this. We'll talk a little bit more about that. So we're going to talk all things bottom of the foot pain today. My model today is going to be Hallie. Hallie is an old employee of ours, and she's currently going through her doctor of physical therapy down at Northern Arizona. She's joined us today to be a foot, so we're going to steal her foot today. Plantar fasciitis, again, is incredibly common. Roughly 10% of us at some point in our life are going to get it. It's one of the most common reasons people go to and seek medical care for foot pain, and it can be quite debilitating. It oftentimes has a long period of time that it's symptomatic, so it's important to address early in its course of care because, again, that reoccurrence rate is quite high, and there's lots that we can do about it. This is one of those things that of all interventions that can be applied to address plantar fasciitis, PT is truly actually the gold standard for helping to address this. And you'll see why with the types of treatments that are shown to be most effective for treatment, especially in the short term once you start experiencing symptoms. The key thing that we always have to address with plantar fasciitis, before we even get into exercises today and talking about all the other stuff that's helpful, is without really reviewing the risk factors that have led to the development of this in the first place and addressing those confounding factors, you're likely not going to get better. And the reason is most of those issues that are coming into play that are causing you to be symptomatic in the first place are likely going to continue unless you change something. We tend to see plantar fasciitis develop in kind of one of two categories, I should say, of individuals. One, it's very high prevalence. In fact, it's the most common foot issue or type of foot pain with runners. And so people that run frequently, and we're not talking new runners or couch to 5K, we're talking marathoners. So people that put in a lot of mileage and tend to have a high foot arch. So we're not the flat-footed, we have actually a high arch position. Those folks have a higher prevalence of developing plantar fasciitis compared to the rest of the population. And their type of treatment will be much different than the other category of folks, where we're talking typically ranges, middle age, 40, 60 years old, women more so than men, higher BMI, and tends to stand, especially for work, where again you have to be in one sedentary place, especially on hard surfaces. It's what it's found. So if you stand a lot, we're kind of in that age category. Like that is a risk factor. And again, some of those things we can't control. Can't control how old we are. Can't control kind of who we are genetically, right? But you can control some of that standing time to an extent at least, or at least how you're loading up your feet. Without changing those things, without changing the running and the volume, and without changing the standing surfaces and how that's going about, there's a high likelihood that this is going to continue. And so before we get into anything like that, those things have to be addressed. So that's my spiel, right? But there are many, many things you can do about plantar fasciitis that has very strong evidence for managing both pain and long-term disability from it. There are specific strengthening exercises for the bottom of the foot that we're going to review first today. Strengthening really is one of those gold standard things to do for the bottom of the foot. The plantar fascia itself is almost basically a tendon throughout the bottom of your foot, and when it is inflamed, the way that we treat that, which is the gold standard, is through heavy strengthening to make the tendon itself stronger, more durable, and more tolerant to loading. So we're going to do an exercise that specifically and preferentially kind of stresses that area to make it stronger. So we'll do some strengthening. We will improve the flexibility of the whole region, so we'll be doing some stretching today to open that area up. There is, again, strong evidence for support of stretching to improve calf range of motion, which can improve symptoms and typically helps you for a period of like a week to maybe up to 4 months. After 4 months of a stretching in isolation, it doesn't seem to be as effective, so it's not a long-term solution. That's why we need to have multiple things that we do to address this. And we will talk about the use of different orthotic devices, so whether we do taping or a shoe insert or other types of orthotics. We'll kind of get to that at the tail end today and show you how that's applied to offload that area so it can calm down. And then if all those things have been applied, if you're like, I've heard all this before, like I've tried some strengthening, I've done the stretching, I've done the night splints, I've done all the stuff, what else can I do? Like, give me more, Steve. Like, well, we'll talk about that. There is more. There's actually quite a bit more, and we'll get into that at the end, okay? So without further ado, we are going to dive into our strengthening exercise first, because this is important. This is a key exercise to implement into your program to improve the durability of the bottom of your foot and make sure that you can tolerate those stresses that are being put into it to make it inflamed in the first place. Okay. So this exercise is performed over the edge of a step or a stair. Okay. Now we just have our stepper here. Let me get this out of the way. Roughly 6-7 inches high. Okay. You do want kind of a flat edge on it. We don't want it too rounded because you're going to come over the edge of it. And I'm going to take a towel, right? So I'm just going to take this small hand towel. I'm going to fold it over a few times, just like that. So I've got, most of it rolled up, and then I'm going to drape the rest of it over the edge of that step. Now what we're going to do is step onto the step where the base of your toe is right before the edge of that towel, and your big toe is on the towel itself. Okay, let's actually do your other foot here, just so you can see the toe right there. Yeah, perfect. Okay. What that's going to do is that pressure is going to be down here. That's going to pull your big toe back a little bit. And the reason we do that is when that big toe comes back like this, that already starts to tension that plantar fascia a little bit. If we roll that up, that's going to lift the arch a little bit when that toe comes back. And then from this position, we're going to do a heel raise, okay? So Hallie's got a little bit of support from the table here to keep her balance. But what we want to do is come down, right? Starting from that all the way down position where you almost have a stretch. You're going to lift up all the way as high as you can. Hold for 2 seconds and control back down over the count of 3 seconds. And then come back up to the count of 3 seconds. So see how controlled that is? We got a 3 second down and 3 seconds up. 2, 3, 2, 1. Good. 2 second pause at the top. So we're going to a tempo of 3 seconds up, 2 at the top, 3 down. That's 8 seconds per rep, which is a long time, right? But what we know about tendon healing and improving the strength and durability of tendons is they respond really well to prolonged tension. So these slow but relatively heavy repetitions tends to stress that area preferentially a little bit more. If we do them rapid, just bouncing, you're not getting that appropriate level of stress into that area. So we need to slow it down. So real slow repetitions, 3 on the way up, 2 second pause, 3 seconds on the way down. If you don't have a stair or a step or anything like this already kind of built in your home or the exercise equipment itself, literally just stack up a couple textbooks. That should be frankly enough. Find a space in your home, usually over the lip of a door frame as well, like going into the garage or out to the patio. It's another spot where you can typically get enough of a space where your heel can come down to go to that range. Classic repetition scheme for this, if you're doing it, 12 repetitions for each set. And we want to start off with maybe just 2 sets, right? And we want to do that every other day. You don't need to do this every day. So 2 rounds, 12 repetitions every other day. When you may get some soreness in your calf, specifically when you do this. You may not even feel it in your foot as much, but because that calf muscle is working so much here, that's where you may feel soreness. You may feel soreness even the next day. You may get a little bit of discomfort in the bottom of your foot as you do this. That's going to be okay. Frankly, on a scale of 0 to 10, 0 is no pain, 10 is the worst pain imaginable. If you're getting kind of a 3, maybe a 4 at the most, pain while you're doing this, that's actually okay. That's what the research is showing us, that if this is symptomatic because it's a tendon, if we're doing strengthening exercises into some pain, that's almost necessary to facilitate the changes necessary to make it stronger and more durable. So a little bit of pain is okay. A little bit of soreness in the calf, that's okay and normal. As this gets easier, just add sets. Okay, so add a 3rd set of it, add a 4th set of it, add a 5th set, add a 6th set. Usually after about 6 sets of 12, that's a lot. You can make this harder by putting on a backpack and throwing some water bottles or textbook or something like that in there to make it heavier and so that it's weighted evenly on your body. You do want to have your hands available for balance and support too, but you don't want to be pushing with it. So if you feel yourself pushing, and if it's too difficult to lift yourself all the way through that motion with just one foot, which may be the case, that's fine. Just use both feet, right? So you can do both feet at the same time from the same manner, both feet on the same towel. going through that motion, there's nothing wrong with you strengthening the other side too. In fact, there's a high degree of occurrence of both feet being symptomatic. So if there's risk factors, there's risk factors for the other side too. So we may as well get it strong and durable so we don't get it on the other side too. Okay. So this is our plantar fascia heel raise exercise. Okay, this is a good one. All right, we've been good on questions. All right, so we got the strengthening down. Okay, next I want to show you two different stretches that you can do to preferentially get into that plantar fascia. There's a ton of different stretches that are out there. I understand that. There's many different ways you can get in and work this area, but the key thing that we want to do is improve that ankle's ability to come kind of backwards, like toes towards you. We call that dorsiflexion. If we're having less than 20 degrees of that, and we'll kind of show you where that is on Hallie when she comes down, but when she comes down to about there, that's about 20 degrees, right? And if we don't have that much motion in the ankle, that's a significant risk factor for developing both plantar fasciitis, but many other ankle and calf issues. With our stretch, we're literally just going to hang out over the edge of that same step, but we've taken away our towel, right? So we've got our foot on it, knee is straight, dropping the heel down until you feel a generous stretch through the back of the calf. And we're just going to hold it. Okay, so we are just going to do a static hold here, right? And we want to be stable, right? So this is where you can use a lot of leverage with your upper body for support and balance. So you feel steady, you don't have to balance on that foot. We want to hold it for at least 20 seconds, okay, but no more than 3 minutes. What the research is showing us and what we see here clinically too is that, frankly, it doesn't matter quite how long you hold it, only that you hold it for 3 minutes duration. So you can do 6 rounds, 9 rounds, if I could do math, 9 rounds of 20 seconds, right? Or 3 rounds of 1 minute, or 1 round of 3 minutes, kind of whatever's most comfortable and you can tolerate and you can still maintain a good stretch. That's how long we want to hold it. So the key is 3 minutes of time in that stretched position with the heel all the way down where you're feeling stretched through the back of the leg. Keep your body relaxed. If you're not feeling much of a stretch here, it's probably because we're still guarding a little bit too much. Everybody should feel a stretch here at some point. Doesn't matter how flexible you are, you can get stretched in this position. So if we're not feeling much of a stretch, think about almost with your body pushing your heel down towards the floor, like you're trying to touch the floor with your heel, or letting your body go heavy, like heavy weight into the leg. It's likely we're still just kind of guarding against that position. So feel your body go heavy, push the heel down towards the floor, and try to get that generous stretch through the calf, and that should do it for you, okay? So this is stretch number 1, okay? Over the edge of the box, the heel stretch, okay? The second one we're gonna do against a wall, so the corner of a wall. So we're gonna go on a field trip. So here, Hallie's going to put her foot up into the wedge of the wall, and you can see how in this position the toe has to come back a little bit. And again, whenever those toes come back, that does preferentially, again, put tension in that plantar fascia a little bit. So in this position, we do get a little more in the foot. Heels firmly on the ground, everything's straight right now. So her shin is lined up with her foot. And what she's going to do to get that stretch is going to think about pushing the hip closer to the wall, and that's going to effectively close that angle down. So it's hip close to wall, keeping everything straight, keeping in line, and you'll feel a nice generous stretch there too. And this will feel different than our last stretch too, because it does get in there a little bit differently than the other. The benefit of this one compared to the other one is that you can play a little bit with your angle, where you're kind of turning your leg kind of maybe away, or you're turning your leg kind of a little bit towards. And that subtle movement can preferentially bias some of these different areas through the back of the calf and into the ankle. So you can really customize your stretch to where you feel that deepest stretch. There's no best position there. It's only kind of where you feel that stretch a little bit more. The ankle is not just a hinge joint. I mean, it doesn't just go forward, backward. It rolls, it rocks, it moves in multiple directions. So we shouldn't just stretch it just straight on. You may need to get into these other vectors, these other positions to stretch. So heels down, toes back. The hip goes close to the wall. Try it straight first. If you're feeling frisky, you can twist, right, away or twist towards to kind of bias those different positions. And if you find a position where you're getting that deeper stretch, Same parameters, minimum 20 seconds, maybe up to 3 minutes, as long as you get 3 minutes of stretch time, okay? So that's our wall stretch. So we've got over the edge of the step, we got the wall. Again, I acknowledge there's a ton of other ways to stretch in this area. The key is that we're opening up that angle. We're increasing that stretch into the calf to improve that motion, because that's the key motion that we need to regain to take pressure and stress off of the bottom of the foot and through the rest of that calf complex. Okay. So those are our two stretches. Those are the two ones I wanted to show you today. Let's jump up onto the table. So again, we know there's strong evidence for stretching. There's strong evidence for strengthening and motion-based exercises. There's also very strong evidence for use of orthotics and using taping short term. Taping the bottom of the foot to offload the plantar fascia is a nice trial way of knowing whether or not the orthotic is going to work for you, because it doesn't work for everybody. Not everybody is a candidate for the shoe insert. It is oftentimes the first thing that's suggested to do because it's cheap and you can just throw it in there, but not everybody frankly needs it. Again, especially the people in that runner category where they already have a high arch, it's like it's not doing anything for you. So doing a trial treatment with taping to see if that unloads things and improves your symptoms is a nice way to know and confirm that you're likely going to do well with a shoe insert. What I'm going to demonstrate for you today is a technique called low dye taping, or an anti-pronation taping, where we just basically support the bottom of the foot with use of athletic tape. Okay, so I'm going to grab this to prop the foot up a little more. All right, so what I've done, I've already created some strips here myself, just for the sake of speed, but this is just athletic tape. Our first piece of tape, like this is torn in half. It's going to start kind of right at the base of that bone right there, at the base of the little toe right there, and it's going to wrap around the base of the heel and then come around the other side, and it's at the base of the other side. This piece of tape is going to act like an anchor for the rest of the ones that we put across the foot. Okay. Now you can do this taping yourself. I've actually shown a lot of patients how to do this themselves. That's why I'm showing it to you today, because you can do this. If you can get your leg to cross over the other and you have the motion in your hip to bring it up there, you can literally do this yourself. Our second piece of tape, it's going to go near the heel. We want it lined up so that the back edge of the tape, if you get in there, is right over the base of the heel. So like the middle of her heel, right there, that's the back end of it. I'm going to anchor it down on the outside first, and that's what's key with all these, so you have the same direction, and so it pulls everything appropriately. Outside first, pulling across tight, coming up, secure it down, and I've got some extra tape there. So, and then we repeat this motion with kind of half tape overlap with each one, right? See how about half the tape is over the top of the other one? And we just repeat that about 4 or 5 times, covering the whole arch. Like that. To finish, we have our other piece from our other side. We go over the top. We trace that again. And we secure it down like that. Okay. Now that will preferentially, again, take pressure off of that. You can, before putting this anchor on, well actually the last piece, if you pull the toe back like that before putting the last one on, you might be able to take a little bit more off, but frankly I found that that isn't truly necessary. Sometimes this will fall off, like you'll put it on like this and you'll take a step and it'll want to buckle over on you. You can put a little strap on the top, but usually it's uncomfortable if we put the athletic tape across the top of the foot. So what I would do is just take some pre-wrap, looks like this. It usually comes close to where you purchase your athletic tape in the first place. And I'm just gonna take a little bit of it like this, and I'm gonna drape it across. And then starting on the outside, just drape it across and secure it that way. And that kind of holds it down from the top down so it doesn't want to bust open on you. So that's a way to just keep it more secure. That's not necessary, but if you notice it's coming off, you can do it that way. So go ahead and jump up and take a step on the ground. And you'll see how much that's lifted her arch compared to the other side. Like if we see that lift right here, and she has good arches already, but that keeps and maintains that lift right here. It takes the pressure off of that fascia. Okay, now she can run in this, she can walk in this, she can do whatever she wants. She does what her therapist tells her to do with it. This is kind of what we do. But usually that will only last you though a day or two with the athletic tape. So it is important that, you know, if this is helping, that you either know how to do it yourself or have someone that can consistently do it for you. But again, what the research shows is that this technique, if it reduces your symptoms significantly, you will do well with an orthotic. So that's a shoe insert. So literally just something off the shelf. Prefabricated works just as well as custom for the majority of folks. So if you go to the store, Dr. Scholl's, boom, shoe insert, it's going to help, right? If you are one of those folks that has to stand a lot for work, sometimes the heel lift works better than the arch support itself. So getting a gel insoled heel lift will offload that area a little bit more efficiently. But nonetheless, this taping technique is a good indicator that that will be helpful for you. Taping typically only is helpful for about 3 weeks. Again, that's on average what the research is showing. So doing this technique is not going to be helpful in the long term. So it's important that you, again, are doing something else besides taping, which most of us typically are. So moving beyond this quickly. The orthotic, it's not, again, the only answer. Some people will use the orthotic and find a significant amount of pain reduction with it. But frankly, what we see is usually only, again, a month to about a year's worth of pain reduction. Because, again, most of the time we're not addressing the actual pathoanatomy of what's happening in that area. And you still see symptom aggravation and the types of overstress into that region that are just not being addressed. So the orthotic can get you by for a period of time, but usually roughly a year is kind of what you're looking at, unless you address the flexibility, unless you address the loading tolerance, unless you address the risk factors. It has a high likelihood of returning or sustaining, okay? Night splints are often brought up as well. So again, when we're having pain that's first thing in the morning, which is literally with those first steps, right, upon awakening, it's kind of a hallmark sign that it is plantar fasciitis and not any other type of heel pain that may be driving your symptoms, because there are other types of heel pain besides plantar fasciitis. But those first steps in the morning is suggestive of that. Oftentimes that's suggestive that the use of a night splint can be helpful. And a night splint is just a device that takes your foot and pulls it into that back position, that dorsiflex position. Go ahead and jump up here for me again. It literally will keep your foot pulled back and toe pulled back a little bit like this and keep you in that position overnight, right? And now it's not supposed to be an aggressive stretch. It should be almost just mild, but being in that position all night helps to just slowly creep into that tissue and allow it to lengthen without being overzealous. And upon awakening, it reduces a lot of your symptoms, but it also addresses some of those underlying factors of loss of motion that's associated with this issue. So that night splint may be a key way to reduce some of those issues and improve the motion in your ankle. Those night splints, you literally can just get them on Amazon. You can go to a medical provider or durable medical equipment manufacturer and purchase them. You literally can get them from Amazon for $20. So there is no best night splint that's out there, in my opinion. I've had patients use many different brands and types. What I will tell you is that the ones that report that they either don't work or they've discontinued use from them are ones where they're kind of bulky. So when you're making your purchase decision, make sure that the size of the actual apparatus that's on your foot and ankle is not cumbersome. Should be as small as possible. It shouldn't take a large device to do the work of this. In fact, there's even a device out there that look like a sock and just kind of clips in. That's equally as effective. You just need something light, because what we find is that it won't be comfortable. You won't be able to sleep well if it's a big bulky device on your foot. You're gonna be kicking around, you're gonna be kicking the other leg, and you're gonna throw the thing out in a week and say it didn't work for me because I couldn't sleep. But the night splint didn't work for you because we didn't use it because it's too bulky. But night splits can be helpful for roughly a month to 3 months of at least symptom reduction, and it can help to speed up the process of recovery or blunt that reoccurrence by addressing that foundational mobility loss. So that night splint can be a key way, if you haven't tried it, to really address those morning symptoms and stiffness in the foot. Still doing good on questions? Man, no questions today. I love it. This kind of brings about the kind of next phase. So if you've tried the strengthening exercise, and you've tried stretching, and you've tried night splints, and you've done an orthotic, and you've changed your shoes, right? And you've gotten good supportive shoes. It's kind of, well, what else can I do? Like, what are some other things that I just haven't tried? What's out there that could be helping me, right? Well, the first thing is, frankly, manual therapy. Again, this is one of those things that has strong supportive evidence from the APTA that says manual therapy plus exercise plus typically orthotic use is more helpful than anything else. So manual therapy being addressing any kind of joint restriction or motion restriction, especially in the ankle and midfoot. So having somebody in there just working that area, opening it up, and especially performing soft tissue work or instrument assisted work. Here at ISSPT, if I can talk today, ISSPT, we use a system called ASTYM. That's ASTYM, stands for Augmented Soft Tissue Mobilization, where we use tools to work that tissue and try to facilitate change and movement and reduce pain in that area and improve local blood flow. So the tools can help to really calm down that area, open it up, and allow for more pain-free motion, to frankly make it more efficient, especially to allow for stretching and strengthening to actually get in there and make some true physiological change. So manual therapy is a key way that you may be able to open up this area, because it's just things that you can't do yourself. That's why it's manual therapy. It's somebody else's hands and equipment doing something and manipulating the tissue around that area to make it more efficient. Okay. I briefly just mentioned shoes. Again, oftentimes a better, more supportive shoe can be helpful. We hear just reporting for patients. There's not a lot of evidence out there about it, but Birkenstocks, man, there's something about Birkenstocks that just you throw them on. It takes a lot of the strain off the bottom of the foot. Invest in a pair of Birkenstocks, I guess. I should get an ad. Should we get an ad for this? We should get an ad for this. Birkenstocks are good. There is evidence to support that rotating your shoes regularly, as in throughout the week. So wearing different shoes throughout the week can be helpful. And then also potentially investing in a rocker bottom shoe. That's kind of, think of those Skechers shoes that had the lawsuit, right? Those tend to be helpful with this. And so getting those, because it just offloads that area. You tend to put a little bit less stress through your foot through kind of mid stance when you're walking, because of that rounded bottom shoe posture. So a rocker bottom shoe may also be helpful. Okay. It is commonplace to have cortisone injections in the foot. I changed my octave there. I just noticed that. And cortisone injections are not sinful. They're not the worst thing on the planet. Again, I'm obviously preferentially biased in my world of rehabilitation, and I don't practice doing cortisone injections. However, there are guidelines around them established by different colleges and medical professionals to guide our treatment decisions. And what the American College of Occupational and Environmental Medicine says directly to physicians is that cortisone injection should not be first-line treatment for plantar fasciitis. It should not be the first thing you get if you have heel pain. That's known. What we also know is that there's roughly a 36% chance of cortisone, after having a cortisone injection, of long-term having an Achilles tendon rupture. So there is a kind of a 1 in 3 chance that it weakens that tissue, because that is one of the major side effects of a cortisone injection is cartilage, well, not cartilage, connective tissue, especially collagen degeneration and wear. And so it weakens the tissue in that area, and that's playing into the whole anatomy of what's causing the problem. This is a relatively speaking, degenerative tendon issue. And so we already have weakening and thinning of that connective tissue in the first place. In its attempts to heal, it thickens with really dense, irregular collagen. And so the tendon itself thickens, but it is ironically weak. And then adding that cortisone injection, while it may help with pain, and where it's shown to be helpful for pain is up to 3 months, and then it dive bombs, is that it weakens it. So I'm not anti-cortisone injection, but for the majority of folks, you get a few months of relief, but there are risks associated with that as well. So we are moving away as a whole medical profession away from cortisone injections for plantar fasciitis because of the risk of rupture, because of the only short-term benefit that it provides. And frankly, again, if there's one premise I've tried to get across today, is that there are risk factors that drive this, and unless you address the risk factors, the thing's going to keep coming back. So the cortisone injection gets you by, but unless you address the other underlying issues, you're going to be going back for multiple, and that's just going to keep increasing your risk. What is shown to be more effective in the short and long term as far as injectables, again, still not in our scope, but there's a lot of promise with PRP injections, or platelet-rich plasma injections. It's showing some promise, and so the use of a PRP injection in that same area has superior effects at 3 months and after a year. So if you're looking for an injectable that's going to calm things down, the PRP injection is a better way to go. Most insurances don't cover it right now. It's still kind of considered an exploratory procedure or an elective procedure. However, if the side effects are much less, the degree of change is much more. And so if you haven't tried something like that before and you've literally tried everything else, I would urge you to consult with a provider to see if that'd be something for you and that it would be safe and effective. For those folks with a heel spur or a bone spur on the heel, this is a common finding that we see with especially chronic plantar fasciitis, is that right at that base, I'm going to pull all this off. Actually, I can just use the other foot. Look at this. Most of the time, the pain is kind of right on that medial calcaneal tubercle, like right there, right at that spot where the majority of that tension and degeneration in the tendon is located. You may start to develop a heel spur or a bone spur. You can develop it in other areas of the foot, but if you have plantar fasciitis and heel pain, and we've failed some conservative treatment, a potential helpful intervention is what's called extracorporeal shock wave therapy. And so again, this is something that is provided by some orthopedic offices, but it's a very intensive form of sound waves that will help manipulate that tissue. And that has been shown with specifically only with heel spurs with plantar fasciitis to be helpful. If there's no presence of calcification or heel spur there, it's no more effective than ultrasound, which has no effect in this area. So only helpful with heel spur. So if that's the case and you've tried all these other things, you can improve. Again, the evidence supports that even with the heel spur, all these things we just talked about, you can see improvement. So having the heel spur on imaging is not a death sentence to have heel pain forever. In fact, you can offload it quite easily, especially with the use of orthotic taping and the mobility exercises. So just be aware that there are some of these other options, like again, PRP injections, extracorporeal shockwave therapy at your disposal. Last case scenario is surgical release. Again, if you've literally gone through all those, which I don't know a human on the planet that's gone through all those things and still had symptoms, but if you do, they will do a surgical recision of your foot. So when we're talking surgery, again, I'm not a surgeon and I haven't seen a surgery of this, but the surgery that they perform, they do a surgical resection where they cut the inappropriate area of the tendon, the degenerative portion of the tendon out, fixate, help repair it. What's the criteria for having a surgery is that you've had recalcitrant or reoccurring pain or plantar fasciitis for at least 6 months or greater than a year and have failed conservative treatment. Again, that's literally the American College of Orthopedic Surgeons recommendations for when to perform surgery on this. So if you haven't gone through a bout of conservative treatment where you've literally tried all these things and it didn't work for you, that's when it's time to be considering surgery. So that's kind of what to look for. But at that point, you can be rest assured that I have tried everything. Like I have tried stretching, I've tried night splints, I've tried orthotics, I've tried stretching, I've had all the injectables, I've done it all. Help me, cool, cut it out, because you know that's the last resort, right? And then at that point, it's likely going to be quite helpful. And you'll also have addressed likely at that point all of the underlying risk factors that could have been potentially causing in the first place. So the likelihood that it's going to come back is far less. So you have a much better surgical outcome if you've taken care of things beforehand. So to recap, we did the heel raise exercise, okay? We did 2 rounds of 12 repetitions, again with the toe underneath the towel. You can progress that exercise by adding more sets, up to 6 sets, going up with a 3-second up, 2-second pause at the top, 3-second down. We followed that with the heel drop stretch, right? And we held that position where we're stretching the calf for minimum 20 seconds, up to 3 minutes. But what we're shooting for is 3 minutes of total stretch time. Okay, so you break it up if you choose a different parameter. We followed that with the wall stretch, with the foot wedged against the wall, toe back, right? Holding that stretch, bringing the hip against the wall with the same stretch parameters. We reviewed taping and how that applies to using an orthotic, and then how you can use a night splint. And then we talked about some other strategies, manual therapy, A-stem, if necessary, moving on to those next steps with injectables, where platelet-rich plasma is better than a cortisone injection, and then why and when you would need surgery. So that's a comprehensive overview of plantar fasciitis. And so hopefully that was helpful. Hopefully you found value in that. If you didn't get a chance to view this live and ask questions, please post some comments and I'll get back to you about those. Next week, join us on Monday. We've got all things knee arthritis. I think this is going to debunk a lot of myths around knee pain, because there's a whole lot of myths about knee arthritis that are out there. We're gonna touch on a lot of it. So knee arthritis on Monday, hip bursitis or side of the hip pain, we just usually call bursitis. It's going to be Wednesday, and then we're going to finish the week on Friday with dry needling, so functional dry needling. It's going to be awesome. It's going to be exciting. Join us. Thanks. Leave your questions.